Thank you for joining us today. Welcome to the American Medical Association's Private Practice Simple Solutions, part of the Steps Forward Innovation Academy. Before we get started with the content, a quick few housekeeping items. The Private Practice Simple Solutions program is a series of rapid learning cycles designed for private practices to provide opportunities to implement actionable changes that can immediately increase efficiency. Please note that this presentation has been recorded and is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. Please take a moment to carefully review this notice. I'd like to now introduce our speaker for this session, Dr. Kevin Hopkins. Dr. Hopkins, please take it away.
Thank you, Sumbul. Appreciate it. It's a pleasure to be sharing the content that I plan to deliver today, and I hope it's helpful and encouraging and enlightening as you go about your day-to-day. I do have some disclosures to share. These are my relevant relationships for companies that have products or services in the healthcare sector for which I own common stock. These are our objectives today. What I hope to accomplish is to define elements that constitute the model of team-based care. We'll identify some benefits of implementing team-based care in your practice. We'll talk about how to implement team-based care in your practice, and then we'll discuss some of the recent challenges to our team-based care model. Really, what we hope to cover is the what, the why, and the how of team-based care. So let's start with what is team-based care? Depending on who you ask that question to, you might get a lot of different responses, but I'll share with you what I think of when I think of team-based care. I think of a model that is higher efficiency than what our standard practice model has been for the last many decades. And I think of a model that helps to increase satisfaction for patients, for caregivers, specifically for physicians, but also for our care team and our teammates. It helps to improve productivity, no matter how you measure it, and it helps to improve documentation quality. Team-based care, as I mentioned, is a higher efficiency practice model, and it's really designed to improve all of those things: accessibility, the quality of the patient care, the patient throughput and efficiency in workflows, and then improving satisfaction and engagement at all levels, from the physician to the employee to the patient. A team-based care model utilizes a team approach in caring for our patients. The responsibilities of providing care are delegated and shared amongst a capable team. Each individual in the chain of patient care functions to the highest level of their qualifications. In short, the physician does what only the physician is uniquely trained and qualified to do. And ideally, everything else is delegated to someone else. Why should we consider a team? I'm sure you can think of a lot of reasons right off the bat. I'll share a few. One reason is that the trend in physician burnout continues to be unsustainable and very troubling. This is a slide that shows a graph of physician burnout rates trended from 2011 to 2021. This research was conducted by researchers through the AMA, Stanford, and Mayo Clinic. They've done national surveys every 3 years since 2011, but due to the effects of the COVID-19 pandemic, an off-cycle survey was performed during December 2021 and January 2022, approximately 1 year after the most recent triennial survey. It was completed by 2,400 physicians in the 2021 survey, and overall, 63% of physicians had at least one manifestation of burnout in 2021, compared with 38.2% in 2020, 43.9% in 2017, 54.4% in 2014, and 45.5% in 2011. This is 40% higher than the general population when it's controlled for hours worked, educational level, age, gender, and relationship status. While these trends were considered consistent across nearly all specialties, there was some variability that was observed, especially in those medical fields that were direct COVID facing, such as emergency medicine and critical care. Another part of this study, questions were asked: would you choose a career in medicine again? The answer for that decreased favorably, or the favorable response to that question decreased from 72.2% to 17.1% from 2020 to 2021. The mean professional fulfillment score decreased from 40% to 22.4%. Satisfaction with work-life integration declined from 46% to 30%. The conclusion in this study is there's been a dramatic increase in burnout and a decrease in satisfaction with work-life integration, and that's occurred in US physicians between 2020 and 2021. So what is burnout? Well, it's a reaction to stress, physical or mental degradation due to a mismatch between the worker and their work environment. It includes depersonalization or cynicism and emotional exhaustion that leads to a relative lack of empathy and a feeling of decreased achievement or effectiveness, whether that's real or perceived. The manifestations of burnout that I just mentioned, exhaustion, depersonalization, and cynicism. The physician impact, it affects our personal relationships, our interpersonal relationships. Physicians who are burned out have higher rates of divorce and infidelity. They have less meaningful relationships with peers, friends, and family members. They have higher rates of early retirement and decreases in work commitment, such as work hours. They have an increase in self-harming behavior, such as getting inadequate rest, alcoholism, and prescription drug abuse. It's estimated that nearly every day in the United States, a physician commits suicide, a rate more than double that of the general population. Burnout also has terrible impacts for our patients. Being treated by a burned out physician increases the risk of a significant medical error. There's less optimal patient outcomes. 54% of burned out residents report suboptimal patient care outcomes. There's lower patient satisfaction scores. Our patients sense our distraction and our discontentment. The odds of a patient being affected by a serious safety event are more than doubled if they're treated by a physician with current symptoms of burnout. There's also significant impact on the organizations and practices for which we work. Productivity is decreased in physicians suffering from burnout, no matter how it's measured. We have a less efficient and engaged caregiver team. There's increased risk of turnover, so it affects access as well as financials. The average cost to recruit and hire a physician to replace one lost to attrition due to burnout is between $500,000 and $1 million, depending on the specialty. So it's a serious, significant financial impact for our organizations, as well as to our and to the individual physicians. This is from the Medscape Physician Burnout and Depression Survey done in January of 2022. The question was asked, what contributes most to your level of burnout? Well, the top answer is probably no surprise. 60% of respondents said charting, paperwork, documentation, and clerical tasks, nearly double the number who responded that they spend too many hours at work. This is also probably not surprising. What has happened to the in-basket as a result of the COVID pandemic? The volume of patient portal messages for the typical practice has increased steadily over the past decade, but it's increased nearly exponentially over the past 2 years. This is data from one EHR vendor that cites an increase in patient portal message volume across all its US users of over 150% since the start of the COVID-19 pandemic. Some health systems have experienced even more significant increases in these messages of well over 200% between 2019 and 2021, and it's not decreasing. This is obviously an unsustainable phenomenon. If not already in place, I encourage you to start a practice improvement project to reduce and redistribute the burden of patient portal messages in the in-basket. We'll talk about that more to come. Some systems are also now billing for in-basket work, which requires medical decision-making, most of which is actually reimbursable by insurance. This is a study that was published in the Annals of Internal Medicine, and it's from 2016. It revealed that half of the day is spent on documentation work for physicians, clicking through the electronic health records. I have a quote that I say pretty frequently now, and that's the sound of tapping keyboards and clicking mouse is the sound of joy leaving physicians through their fingertips. For every 1 hour of direct face-to-face patient care, we generate 2 hours of indirect care in the electronic health record. And on average, physicians spend 1 to 2 hours per evening doing work after work. This is a study that was published in 2017 from University of Wisconsin, shows that the average physician does 32 hours of work after work per month. That's nearly equivalent to an additional week of productivity every single month. This graph shows the percentage of EHR users logged on at any given time. The blue line shows weekdays, and the red line shows weekends. And so you see the peak hours obviously are from 7 a.m. until 6 or 7 p.m. Monday through Friday, but you see those tails, and that's in the evening time. And when you look at the red line and think about how that represents weekend days, Saturday nights belong to the EHR. It's sort of our date night. And I don't know about you, but that's not who I would want to be sitting beside on the couch. We got a time problem. This was a study that was released just last year in 2022, and it is a re-examination of a study that was done in 2005, updated, an update to Kimberly Yarnall's work that was published at that point in time. They estimated the amount of time it would take to care for a panel of 2,500 primary care patients. If you consider all the chronic disease management that needs to be accomplished for that group, it's 7 hours a day. Preventative care, 14 hours a day. Acute care, 2 hours a day. Documentation and inbox, almost 3.5 hours per day. The sum total, 26.7 hours per day. If taking care of patients today seems impossible, that's because it is. To deliver the necessary and recommended care for a primary care panel of 2,500 patients, it would take 26.7 hours per day. There's more work to do than we can or should do. We need more time. So what can your practice do? Well, there's a couple of things. I want to pivot now to turn to some solutions. One is to stop the unnecessary low value work. I'll get into that more specifically. The second is to share the necessary, more valuable work. And that's really gets to the crux of team-based care. So first, stop the unnecessary low value work. What do I mean by that? Look for opportunities to de-implement unnecessary work, especially tasks that are due to interpretation of regulatory requirements. When you ask questions like, why do we need to do it this way? Or why do we need to actually ask these questions of our patients? Or why do I need to click this button in the EHR? And the response that you get is, well, it's a regulatory requirement. The next words out of your mouth should be some variation on the theme of, can you please show me that regulation and help me understand where it comes from? A lot of times, these types of restrictions and things called regulations are self-imposed by our own practices or our own healthcare organizations. Sometimes they are from outside regulatory agencies, such as state and federal authorities. But looking for opportunities to get rid of things that we don't need to be doing, that don't add value to the care that we're delivering to that patient that day, is a great way to save time. Other things I'll say are, we have a phrase at the AMA called getting rid of stupid stuff or gross. And this is, again, a variation on that same theme, getting rid of the things that we do that aren't necessary. Frontline caregivers often think about this. Why do we do this? It really doesn't add value to the care today. Well, how can we de-implement some of those things? How can we decrease the EHR inbox noise, unnecessary messages coming to the physician? It's estimated that 70 to 80% of the inbound EHR inbox messages for physicians don't need to be handled by the physicians. So who else can handle those? Or are they even necessary in the first place? When we get to more of the specifics on team-based care workflow, I'll talk about that. Also looking for opportunities to simplify documentation, getting rid of some of the note bloat. There were updates to the billing and coding requirements and guidelines, CPT guidelines that came out in 2021. A lot of practices and individuals still are going off the old billing and coding system. But now we can actually bill a level of service based on two factors: medical decision-making or time spent on that day. We no longer need to have the certain number of bullet points for history and physical exam and all of those types of things that we've been doing since at least 1995. So think about what you document in your chart, in your notes. Is it really necessary? Does it just add fluff and words? Or is it actually important that that content rest within the medical record? If it's not, then get rid of it. Stop documenting things that are unnecessary to provide adequate care for the patient on a given day. We'll move now from reducing and ideally stopping unnecessary work to opportunities to share the necessary work, which brings value to the care of our patients. So how can we do that? How can we share the necessary value-adding work? Well, think of something that a physician does as a part of their typical workflow that they did not need to go to medical school in order to do. If it's something that has to be done, who else could do it? There's opportunity for great efficiency if we take a look at these types of workflows. What do you wish that other members of your team would start doing instead of the doctor doing? What do you wish that they would do differently or do better? Taking the time to educate and engage our care teams around sharing the necessary value-adding work will be a great investment in the long term for staff engagement, for physician burnout, and for quality of care delivered. Looking for opportunity to improve staff engagement and enhance the caregiver experience is beneficial to everybody. It'll help to decrease turnover, frustration, fatigue, and as I said, burnout. So opportunities to look for would be team documentation. What I mean by team documentation is sharing the documentation burden of ambulatory care visits. So who documents in the chart? Who documents the progress note? In most practices, it's 100% or nearly 100% the physician, but that documentation can be shared among a team. Looking at rooming and discharge protocols, how can we sort of advance that so that it's not just the standard check the vitals, review the medicines real quickly, and then get out of the room so the doctor can come in, but it actually adds value and meaning to the care that we're delivering on that day. We'll talk a little bit today about pre-visit planning, specifically pre-visit lab testing. We'll discuss annual prescription renewals and medication management, and then we'll do a little bit on the EHR inbox and how to manage that. In few other sectors of the economy is the highest level professional responsible for the majority of production, customer service, and clerical work. This is from the SGIM Blue Ribbon Panel report on redesigning the practice model for general internal medicine way back in 2007. And it's no less true today. In fact, it's probably more true. We have the highest level professional doing the most amount of work that is probably unnecessary for them to do and could be and really should be done by somebody else in the team. So what's the time solution? Well, if we put into play the team-based care workflows that I'm going to talk through today, how can we favorably affect that amount of time that it takes to care for 2,500 patients in primary care? Well, our amount of time that we need to spend on chronic disease management will decrease to 3.5 hours a day. Preventative care, 2 hours a day. Acute care, just over an hour. Documentation and inbox, 2.5 hours, for a total of 9.3 hours per day. And so that's utilizing team-based care principles. We move from that 26.7 hours per day down to 9.3. The largest decreases are in preventative care and chronic disease management, but the impact on documentation and inbox is likely underestimated from this study because I suspect the impact will be even more significant than that. So we're going to spend the next chunk of time talking about sharing the necessary value-adding work and some high-yield team-based care workflows. These are sort of the key takeaways from today. One effective method for beginning and advancing a team-based care model is to consider the staff and resources that currently exist in a practice and start to reimagine who does what. Recognizing especially the current challenges with workforce availability, it may be more feasible to consider starting small with some relatively minor task sharing among your existing team than it is to think about completely overhauling your staffing model and bringing in a lot more people. Maybe a new process which engages the care team in collective transformative work is more immediately plausible. The best predictor of a change to be successfully implemented is one which is mutually beneficial to patients, care teams, and health systems or practices. So let's talk about team documentation. When I talk about or think about team documentation, I mean real-time in-room documentation support, somebody at your side. And that could be a clinical team member, preferably a medical assistant or a nurse who's sitting at a computer, who's also done the intake for the patient for that visit, but then sticks around for the remainder of the visit, building a relationship with them and becoming a critical member of the care team. It could also be a trained documentation specialist, such as a scribe. More and more of these services are in existence now, and more people are using them. But I mean, when I think about team documentation, I mean somebody to help with the visit note, somebody to help with the documentation, the keystrokes and the clicks, updating the chart, updating the history, attaching diagnoses, pending orders. When you think of the amount of time that it takes in most EHRs to put orders in, even just for a routine visit, it's somewhat staggering. I had an experience not long ago where some of my family members were watching me place an order for a test for somebody, and they said it takes that many clicks to be able to put that order in. Yeah, absolutely it does. It's not the most efficient system in the world. So we need help with documentation. This is a chart about tasks that medical assistants or other team members can complete under advanced protocols. We tend to think that everybody just stays in their lane and has a very defined role and responsibilities, but those roles and responsibilities can be reconsidered. I mentioned reimagining who does what. What might look different if you were designing your practice from the ground up, starting new? Well, these are some things to consider. When it comes to rooming patients, medical assistants or nurses or other team members can help set the agenda for the visit. They can review medications and pen refills. They can initiate condition-specific screening and pending tests relative to those things like colonoscopy or mammography. They can anticipate symptom-driven testing and go ahead and get a urine sample for somebody with UTI symptoms, or an EKG for somebody with palpitations or chest tightness. They can update the pertinent histories in the problem list. They can update health maintenance and address topics that are due or overdue, including administering immunizations based on standing orders. They can pend expected orders from the outcome from the visit today, and the physician can file them or can cancel them if they're not necessary. Our staff can help us by handling any forms and drafting letters. They can stamp them with the office information and a signature stamp, or flag it for signature if a hand signature is required. Our staff can also have the most recent tests available, the test results that the patient may have had recently, blood tests or imaging tests, and make it easy for the provider to review either in paper form or electronically. And then team documentation, as I mentioned. The clinical staff, when they're doing rooming intake, is already collecting some intake information. Most of the time they're writing it on a face sheet or some other piece of paper, or they're just remembering it. But since they're already collecting really a big component of the chief complaint and history of present illness, why not ask them to go ahead and document that in the chart and teach them how to do it? It just may be a portion of the electronic health record they're not used to accessing in this way, but they can certainly be leveraged for this type of work. It's the first step towards real-time in-room documentation support and visit-specific documentation template use. They can help to document patient answers to history questions in a note template, such as the Medicare annual wellness visit or well child checks, or review systems in a comprehensive physical exam. When it comes to a discharge protocol, our support staff can help by printing, delivering, and reviewing an after-visit summary if that's the workflow we choose to use. They can review and reiterate instructions and answer any final questions. They can stay in the exam room and schedule the follow-up visit at the proper interval and make sure that any indicated pre-visit labs are already ordered. They can perform charge entry for the nursing tasks that they perform and also have a warm handoff to the next team member if that's a clerical person at the front desk, or they can discharge the patient from the exam room. Pre-visit planning and lab testing. Pre-visit planning adds value by helping patient visits really go more smoothly and be more productive, and that work can be shared across a team. Pre-visit planning for the next appointment begins at today's appointment, And that could be as simple as ordering tests at today's visit to be completed before their next appointment for a patient with chronic disease like diabetes or hypertension. This way, the lab results that are important for clinical decision-making are available and actionable at the time of the visit rather than afterwards. That helps to eliminate the need for additional post-visit asynchronous communication with the patient. Primary care teams and health systems have developed and implemented pre-visit planning protocols for patients with certain chronic diseases, also for monitoring of medications, and even for screening and preventative care. Some pre-visit planning systems are very simple and straightforward. Some are highly sophisticated and utilize technology solutions to automate the process, individualized for each patient. But regardless of how they function, they have the opportunity to help us introduce and leverage evidence-based protocols for health maintenance, chronic disease, and medication monitoring. This is a study that was published from Massachusetts General, and it was in 2013. They implemented pre-visit lab testing in their practice, and some outcomes that they saw as a result: 89% decrease in phone calls, because you don't have to call the patient with the test results. 85% decrease in letters sent to address results. 61% decrease in additional visits. All of a sudden they became unnecessary because the lab results were available ahead of this visit rather than after, necessitating an additional visit. And they saw a 21% decrease in the number of tests ordered. A lot of organizations see this when they go to evidence-based protocols for standard structured pre-visit lab testing. Additional things that they noted as outcomes were improved patient satisfaction, and it also led to savings of $26 per visit in the direct cost of care. I'll talk about annual prescription renewals. One of our colleagues uses the phrase 90 plus 4, don't call me no more. Other than being atrocious from a grammatical standpoint, it's really effective to help me remember to do annual prescription renewals. And what I mean by that is to renew prescriptions for all chronic daily medications at the same time, synchronized, once a year for each patient. Ideally, those prescriptions should be written for slightly more than a year's supply. So that might be 90 days plus 3 or 4 refills, depending on your state pharmacy laws. And ideally, that would be done at an annual wellness or chronic disease management visit. The patient should be instructed to continue to follow up in the office at appropriate intervals, but we no longer need to use the prescription as the hook to get the patient back in, because it doesn't work anyway. Also, prescribing medications in this manner does not increase no-show rates, contrary to popular belief, but it helps to save unnecessary time doing prescription refills going forward. We've all had that experience for the patient who contacts the office today for a refill on their metformin, and then 2 days from now, we get the refill request for their lisinopril. 2 weeks later, we get the request for their atorvastatin. So this helps to avoid that and bundles and synchronizes all of our chronic disease prescription renewals at once. A little bit about team-based workflows for EHR inbox management. This is a diagram that shows a way to think about how we would triage the EHR inbox and who could do what. There's really 4 types of in-basket messages. There's clinical questions. Those clinical questions are things, only messages requiring the medical decision-making and ready for provider action should find their way into the provider's in-basket. Diagnoses and orders should be pended for the requested referrals or tests if the patient has a specific request. The second bucket is non-clinical questions. Non-clinical questions should not come to the provider in-basket. Most shouldn't even come to the clinical staff in-basket. They should be rerouted to a clerical staff in-basket and should be handled by the most appropriate person, especially if it's related to scheduling and logistics. The third bucket is a request for refills on medications. Refill requests should first be reviewed by clinical and clerical staff for accuracy. And then if we use the annual prescription renewal protocols, we'll renew all their chronic medications at the same time once a year, and it saves that future fragmented work. And then I also wanted to mention forms and letters. Again, this is something that shouldn't come to the provider's in-basket. All of these things that can be handled by somebody else should be handled by somebody else. All messages should route first to the support staff for review and action. Any message that can be handled by someone other than the provider should be. So we'll use the last little bit of our time together today to talk about recent and current team-based care challenges. So some of them are direct effects of the COVID-19 pandemic. So things like social distancing, which is a phrase that we probably never heard before the spring of 2020. Telehealth visits. When we had to pivot to telehealth visits, we sort of went back to the doctor does everything mentality, and through some of the advances we had made in-office team-based care out the window. Telehealth hasn't gone away and isn't going away. And so it's a good time for us to stop and think about how we integrate our support staff into how we deliver care through telehealth platforms. During the pandemic, 40% of US working parents either voluntarily reduced their hours or quit their jobs. Of those who quit, more than a third do not plan to rejoin the workforce. Women's participation in the labor force is the lowest in 30 years. It's particularly present in our healthcare setting, where a lot of support positions tend to be filled by female candidates. The healthcare segment of the US economy has been particularly hard hit. The number of job openings exceed the number of unemployed, and it's the largest gap on record. Those seeking employment are at a 20-year low. Healthcare has the fewest job seekers of any industry. People are quitting at record pace and seeking better opportunities with higher wages and more flexible work arrangements. Even just thinking about the nursing turnover. In 2019, nationwide RN turnover was at 15%. In 2020, it was at 18%. 2021, 30%. And in 2022, nationwide RN turnover was greater than 35%. So we've got significant issues with workforce availability and staffing shortages that we're all experiencing. So what would you do after today? How would I even get started with team-based care? What would I even think about? Who would I even talk to? Well, first of all, I want to direct you to some resources that are available. Most of the content that I'm delivering today is from Team-Based Care Steps Forward toolkit that's available through the AMA. It's open access. You don't necessarily need to be an AMA member to access these resources through the Steps Forward series. The content is great. There are articles that are a relatively quick read. Most of them take 3 to 5 minutes. Some are a little bit longer if you want to learn more. They have PDFs and downloadable resources associated with them. Some of the downloadable resources included in this team-based care toolkit include a core concepts for team-based care PDF, core principles for team-based care, visit prep checklists. So some of the advanced intake things that I've talked about are available as downloadable resources. In addition, things like a visit planner checklist, rooming checklist, pre-visit questionnaire, and discharge checklist, all to help us reimagine who does what in the workflow of patient care. Within this toolkit, it talks about 5 steps to implementing team-based care in your practice. Step 1 is to create a change team. Start bringing some people together who represent different work level and skill sets within your practice, and think about what might be different if you were to design the ideal practice. Start designing team-based care workflows to fit your goals. If one of your goals is to decrease the number of follow-up phone calls or letters sent for test results after visits, maybe you want to think about pre-visit lab testing as your first goal. Select a pilot team. Bring people together that are a combination of decision makers, frontline workers, people who are encouragers, and people who are innovative, and just people who are interested in figuring out ways to do things better. Recognize that role flexibility is part of practice culture. So we need to make time for team members to learn new responsibilities. And a big part of that is eliminating unnecessary activities and waste. In healthcare, and I suspect other industries are the same, we tend to layer on more and more job responsibilities. We hardly ever say, I'd like you to start doing this. And as a result, you can stop doing that. But I think those things need to come in tandem. We need to get rid of some of the lower value, unnecessary care or work or tasks that we do in order to concentrate and focus on the more value added work, care, and tasks that we can do. And then as you design those workflows that are team-based, look to implement one. Maybe start with pre-visit labs. Maybe start with advanced rooming and intake. Maybe start with annual prescription renewals. It doesn't matter what you start with, and it could be something entirely different that addresses a problem that is specific to your practice. But the key is to start something and see what happens as a result. Track outcomes and then work on optimizing your process. Don't just be one and done, but continue to iterate, to think and see how you can do things better. Once you've had one success, parlay that into future successes by taking on the next thing. It can be fine to start small. In fact, that's what I would encourage you to do. Think about one small change that if you did it, would make everything else in your daily workflow just a little bit better. There's lots of reasons to do this. I mentioned at the top of our time together some of them, but one that we can point to is that burnout costs healthcare systems. So part of why I show this and talk about this again is to help you think about the business case for why change is necessary, to including more team-based care workflows and de-implementing lower value tasks. It's because we're burning out. We're burning physicians out at an alarming rate. Physician burnout costs total $4.6 billion per year. That equates to about $7,600 per employed physician per year. And this was, again, research from the AMA, Stanford, and Mayo. It was published in 2019 to help estimate the costs that are associated with burnout-related physician turnover and reduced clinical hours. This doesn't even include costs due to increased medical errors and malpractice claims and decreased patient satisfaction. The costs here are limited directly to turnover and reduced clinical effort, replacement, and lost productivity. Obviously, this research supports substantial economic value for investments aimed at reducing physician burnout. As a part of the AMA Steps Forward toolkits, we have calculators like this that can help you calculate the risk of or the cost of physician burnout to your practice or your organization. You plug in the number of physicians, the current burnout rate from survey data, if you have it, or the current physician burnout rate from all causes. And that'll help you to predict the number of physicians in your practice or your organization that you can expect to lose due to burnout-related turnover in the next year, as well as the dollar cost of that turnover and an estimated cost savings and return on investment for investing in burnout intervention. This is a coned down view of the estimated savings from practicing in a team-based care model. So the workflows that we just talked about, you don't have to implement all of those to realize these savings, but getting started helps to move you down the road. So I'll close with a couple of things. We can't do it alone. And we also can't do all of these things at the same time. If you want to redesign your practice and make it better, you've got to start somewhere. So recognizing that you can't do all of these things at the same time, but you can choose to do something right now. So what is the one thing that you'll take away from this webinar today that you could start doing differently tomorrow, or start having a conversation with your team about? Because if we continue to do the same things the same way over and over again, we're going to end up with the same results. And the results that we currently have, whether it's related to physician burnout, caregiver staff turnover rates, patient quality and outcomes, and the effects we're having on our organizations and practices, it's not good. And so we need to start doing something different in order to get a different result. So thanks. That's what the content that I had to deliver today, and I hope that you were able to enjoy it, be somewhat encouraged and hopeful as a result of it. But I'm happy to engage with you on the discussion board. The link to access that discussion board is included here on the slide. I'll be having office hours every Friday afternoon throughout the course of this session, and we'll be happy to answer your questions and engage in comments and discussion, and anything that you want to talk about that that relates to team-based care and practice efficiency. Sambal, anything else that you need to add to wrap us up today?
No, thank you so much for sharing your time today with us, Dr. Hopkins. That concludes our presentation. If you could just go to the next slide, there's a link there to access other additional resources, relevant information for everybody. Thank you for joining us today.